Andrew, pharmacy shelves sell 5-HTP as if it is a gentle sleep and mood switch. Viewers keep asking whether swallowing a serotonin precursor really changes sleep, mood, or appetite, or whether the bottle is mostly marketing dressed up as brain chemistry. Where should we start before anyone tries a capsule for nights that feel broken?
Start with the molecule, not the slogan. 5-hydroxytryptophan is the immediate precursor of serotonin. In the pathway, dietary tryptophan is converted to 5-HTP, then decarboxylated to serotonin, and serotonin can later feed melatonin synthesis. That cascade is why people treat a 5-HTP capsule like a shortcut into the serotonin system instead of waiting on ordinary protein intake. The practical pitch is that 5-HTP bypasses the rate-limiting hydroxylation step that turns tryptophan into 5-HTP. In controlled animal work, enteral 5-HTP can raise circulating serotonin because you skip that bottleneck and still get downstream metabolites. Hold on to that as mechanism, though, not as proof that a retail capsule will fix insomnia, low mood, or stubborn fatigue.
Does that shortcut even reach the brain in a meaningful way? People compare tryptophan with 5-HTP constantly in those explainer videos. If 5-HTP crosses the blood-brain barrier, why is the human evidence for sleep and mood still so uneven?
Yes, 5-HTP can cross into the central nervous system and support serotonergic neurotransmission. That is the cleanest part of the story and the reason Graphonia extracts get marketed for mood and sleep. The messy part is translating higher precursor availability into better sleep scores, better mood, less pain, or less fatigue. Those are different physiological jobs, and trials test them separately.
Then stress test the sleep claims specifically. If someone buys 5-HTP because nights feel broken, what did a controlled trial in older adults actually show at 100 milligrams a day over 12 weeks, using both diaries and wearables?
The sleep signal was real, but selective. Overall, 5-HTP nudged some sleep quality components and raised serum serotonin. The clearest subjective win was in people who already slept poorly. Their global sleep score improved by week 12, while good sleepers did not show the same story. In those poor sleepers, gut microbiota diversity and short-chain fatty acid-linked taxa also looked more favorable. So the best-fit sleep user in that evidence is not every tired shopper scrolling late-night supplement ads. It is closer to an older adult with a frankly poor sleep score, using a measured 100 milligram regimen and judging progress over weeks rather than chasing overnight magic. If baseline sleep is already decent, expect little from the same capsule.
What about mood and thinking next? Plenty of videos promise 5-HTP for depression and anxiety as if a serotonin precursor automatically equals an antidepressant. Did the older adult cognition and mood trial actually move clinical-looking scores or mostly blood serotonin?
In that trial, the 5-HTP group improved MoCA performance and showed a drop in geriatric depression scores, an interim checkpoint, with higher serum serotonin. Anxiety scores and several other biomarkers did not move the same way. With only 30 participants and 12 weeks, read it as promising and preliminary, helpful for hypothesis generation, not a depression treatment protocol you can download from a bottle label.
That is exactly where viewers get scared, and should. If 5-HTP can raise serotonin, is combining it with an antidepressant or another serotonergic product the real danger people warn about in those long-term use and #1 danger videos about stacking?
Yes, Xai's practical point applies hard here. Supplements may interact with medicines or become risky with certain medical problems. 5-HTP is not a casual add-on to antidepressants, MAO inhibitors, migraine serotonergic drugs, or other serotonin boosters. FDA's consumer framing also reminds people that dietary supplements are not handled like approved drugs. That whole medication review belongs with a clinician before the first capsule. Here is the cleanest antidote to hype. In people with quiescent inflammatory bowel disease and clinically meaningful fatigue, 100 milligrams of oral 5-HTP twice daily raised blood 5-HTP and serotonin, Yet fatigue scores did not beat placebo. Roughly 1 in 3 patients improved on either arm. More serotonin in the blood did not equal less exhaustion.
So, if fatigue was a miss, what about the appetite and body composition pitch that always shows up around serotonin talk? Did 100 milligrams change fat mass in trained adults? Or is that another overstretched claim?
There was a narrow signal. Fat mass fell in the 5-HTP group, and that change differed from placebo, while lean mass, body water, and reported food intake did not clearly shift. The investigators themselves framed the result as limited preliminary data. Useful curiosity for body composition research, not a physique program or appetite cure. Pain marketing also overreaches the evidence. In healthy volunteers, 28 days of Graphonia simplicifolia at 100 milligrams daily barely moved experimental pain measures versus placebo after sensitization testing. The only notable difference was a wider area of mechanical allodynia, which may hint that serotonergic facilitation can sometimes amplify pronociceptive pathways rather than deliver analgesia.
If someone and their clinician still decide on a supervised trial, how should they judge whether it is helping in real life? What would make you say the experiment failed and expectations should change instead of dose chasing forever?
Judge with one pre-chosen endpoint, a realistic multi-week window, and a hard exit rule if nothing moves. Also remember, store products can differ from study capsules, and concentrated 5-HTP is not the same exposure as food tryptophan. Pregnancy, planned procedures, and complex disease all widened the clinician boundary before anyone's self-experiments. So the fair map is this. 5-HTP is a real serotonin precursor with central access. The strongest human support so far is selective sleep help in poor sleeping older adults, with early cognition and fat mass signals that stay provisional. Fatigue relief in IBD and experimental pain relief look weak. Biology can be true while the bottle still overpromises, and interaction risk still deserves a clinician gate.